morning, everyone, and thank you for joining us today. Our esteemed guest today is Dr. Leslie Waltke. Dr. Waltke is a physical therapist with a clinical mastery in cancer rehabilitation and the founder of the Waltke Academy for Rehabilitation. Try saying that 3 times fast.
Right.
And she will be speaking today about rehabilitation and recovery after breast cancer and how to get all of you back to strength and moving and living your best lives. So, Dr. Waltke, thank you so much for joining us, and the floor is yours.
Thank you, Miss Ambrose, as always, and welcome everyone. I will tell everybody I'm recovering from allergies, which still make me cough occasionally, so I apologize in advance for that. So, thanks for that intro, Sherry. So I have been an oncology physical therapist for more than 30 years. So this is a topic that is near and dear to my heart. I am excited to be with you again today. So what we're going to really talk about is regaining full chest and shoulder mobility, comfort after surgery and radiation. We're going to be talking about minimizing the fatigue, the neuropathy, and the weakness that many people have after treatment or during treatment. We'll talk about lymphedema risk reduction and ways to reduce your recurrence risk of your breast cancer. And then we'll also talk about not only is weightlifting safe, but it is effective at protecting you from lymphedema, from recurrence risk, from shoulder problems, from bone density loss. So those are the things we'll be covering today. And we will have a Q&A at the end. So write them down and make sure we get your questions answered. A couple of the highlights I want to stick out right at the beginning here is that when it comes to fatigue, which is the most, we'll talk about it more, but it's the most common, one of the most distressing treatments or side effects in all of cancer, especially breast cancer. And one of the best treatments for fatigue is exercise, which again can seem a little counterintuitive, but it's research-based, and people that out there that have moved know, wow, it really actually does make me feel better. So the stronger you are, the less susceptible you are to fatigue. I'm also going to say right away, because we will go over this again, but the more times you hear it, the easier it is to remember it. When we talk about exercise, I'm going to say anything is better than nothing and slow is better than no. So if you can get up and do a 5-minute walk, that's better than sitting on the couch. The target suggestions, though, that are research-based, but from the American Cancer Society, are we want most people, men and women, to be targeting about 150 minutes per week of moderate exercise. So that is something that kind of gets you a little bit out of breath, but it doesn't exhaust you. So that comes down to about 2.5 hours a week, or 15 to 30 minutes a day, most days of the week. We want you doing something aerobically about 4 to 6 times a week. So walking, swimming, bicycling, dancing. And then we want you weightlifting or strength training 2 to 3 days a week. And that is important during treatment. That is incredibly important after treatment. And it is incredibly important for the rest of your life. Yes, when you get into your 70s, 80s, and 90s, this does not go away. The stronger you can keep yourself, the better you're going to function through your lifespan. We'll also talk about why physical therapy and this exercise component is so important. And it is important because it improves quality of life, which of course is important. But we're going to talk now that, yes, that's a good thing, but it also increases how long people will survive. It can impact recurrence risk. It decreases risk of dying from the other crap that kills us, like heart disease and strokes and all those things. So this isn't just a nice to. This should be something that is incorporated into the daily life of every cancer survivor. Now, we'll talk too about if somebody has a knee surgery, a back surgery, or a stroke, they automatically get shuffled into physical therapy because they have lots of impairments. Well, people that go through cancer treatment have lots of impairments. And unfortunately, they're just kind of left under-recognized and undertreated in most situations, in most places. We're moving the needle on that. But any person that goes through cancer treatment because impairments are caused by surgery, chemotherapy, and radiation, basically anybody, regardless of the type of cancer they have, should get access to physical therapy. We will also talk about that. Now, let's talk a little bit about impairments. We know the very famous saying, cancer sucks. And it has a lot of reasons that put it in that category. But many of them are, again, the fatigue, the pain, the weakness, the numbness and tingling, the limited motion, the balance problems, and the walking problems. These are very common. And again, they're traditionally undertreated, but we can do many things to either make them less or to literally make them go away. So the American Society of Clinical Oncology, again, this stuff is well known. We all know that chronic pain can be a serious negative consequence of surviving cancer. And in breast cancer, the prevalence of pain in cancer survivors has been reported as high as 40%. That is ridiculously high when most of that we can make go away. So I bring that to your attention because I love watching the shifts that happen in time over the decades that I've worked in oncology. And now the voice of survivors is louder than ever, and it should be, because now we are being forced to pay attention to the things that people are living with. And because the population of the United States and the population of the planet is getting larger, and because the population is getting older, which is a good thing, we're all living longer, that means more cancer diagnoses, because the more people equals more people to get cancer, and most cancers are more prevalent as we get older. So more older people, again, means more cancer. So just those two things alone, increased population size and increased population age, are going to mean we are going to have more people living with cancer. And because the death rate is dropping, because treatments are getting better, more people are surviving cancer. So when you wrap all those things together, that is why we're seeing that massive increased bubble of cancer survivors. I think there's 19 million just in the United States and 53 million plus across the entire planet. And again, these people are having most of their survivorship needs still under-addressed. So again, your voice is incredibly important. So don't ever feel alone, because you are one of a strong force of 53 million people. And again, the studies have shown that, like when you have a stroke, when you have a rotator cuff repair, after you've been in a bad car accident, that cancer rehab are linked to improved outcomes. Again, but not just for morbidity, which means how crappy do you feel, but it improves outcomes in mortality. How long do people live? So it's a really, really important piece of cancer care. So we're talking a lot about side effects today. So let's see how that fits into the whole picture of cancer. All right. So cancer diagnosis typically is done by your friends in radiology and your friends in pathology. Okay. Imaging and biopsies. Once that diagnosis happens, you get transferred over to an oncology team, which includes maybe a surgeon, maybe a radiation oncologist, medical oncologist for sure. And for people who have breast cancer, it's going to include hormonal therapies and possibly biological therapies if you're HER2 positive. And those things are the things that lead to this side effect profile. All right, so the fatigue, the pain, the weakness, the loss of range of motion, the bone loss, the muscle loss, the weight loss, and a lot of times weight gain, the stiffness, balance issues, neuropathy, all of that stuff happens as a result of those treatments. And that's where your rehab therapist comes into play in your cancer team. So let's specifically break those down a little bit, and we're going to look at your cancer treatment from specifics from surgery, then radiation, then chemotherapy, and then we'll look at survivorship issues. So side effects from the typical cancer, breast cancer treatment include pain, limited range of motion, scarring of the skin and the tissues, soft tissue shortening, which is skin shortening, tightness, muscle weakness, and of course that's going to lead to limited function. And some of you who have had lymph nodes removed from your armpit may have had a condition called cording, and even sometimes swelling. And I'm actually going to show you some surgical pictures that really kind of show that in the real world. When it comes to chemotherapy, typical side effects include fatigue, weakness, pain. Weight gain is a problem for many people. Weight loss is a problem for many people. As you know, it can cause neuropathies. It can cause stress to your heart muscle. It can cause muscle loss, bone loss. And again, that all leads to loss of function. From radiation, side effects can include, now we have to split it kind of into two pieces with radiation. So the acute effects those are the things that happen when you are actually undergoing your weeks of radiation. So fatigue, the skin reaction or that skin burning that you see or feel, pain and loss of function. That is while people are going through it. Now, late effects are those things you may have heard that radiation is the gift that keeps on giving. So radiation, like scar tissue after surgery, doesn't happen overnight. It is something that happens over months or years. And that's called fibrosis. And that is just where the skin and the connective tissue just kind of slowly thickens and tightens and dries out. And that can cause discomfort. When people have discomfort, they move less, which means they get weaker, and then they can actually have some loss of function. So when we talk about successful cancer care, especially we on the healthcare side, we have been for decades focused on just getting people to stop dying, right? 1960s, 1970s, people were just getting emaciated by cancer. Nobody was living. Very, very few people were living. So that was the primary focus. And that's kind of how the whole cancer treatment platform was built, to get people to stop dying. And we've become so much more successful at that. However, it trashes people in the process. And now we're like, okay, yeah, we're doing this good work, but look what we're doing to people, because now they're actually living. So we have to progress the definition of successful cancer care to, yes, we want to eradicate disease and its progression, but we also need to do that while returning people to their pre-diagnosis activity level, their comfort levels, and their function levels. That is truly successful cancer care. Because what is the point of getting rid of somebody's cancer if we've trashed them in the process and they can no longer be who they want to be or who they were? So let's now look at your surgery, okay? So again, the benefits for physical therapy, people live better, they live longer, more are going to survive, they're going to have less fatigue, less pain, less weakness, better cardiopulmonary function, maintain improved body mass index, and then you're going to recover faster post-treatment. And post-treatment, you're going to live better, stronger, and happier. So I'll make another little plug right here is I don't care how far you are. If you're in cancer treatment right now, or if it was done 10 years ago, if you don't feel strong, fully mobile, don't feel like you've recovered 100%, it is never too late to ask your team or even your primary care physician for a referral to physical therapy, because it's never too late to get better. Okay, so let's just quickly take a look at the chest wall. All right, so we have breast tissue on the top here. And we have right underneath that breast tissue is lymph nodes that kind of congregate in the armpit. So most of the lymphatic fluid from the breast drains to the armpit. So that's why surgeons will typically remove lymph nodes from the armpit, because if cancer cells are going to leave their original location in the breast, they're going to get out of the breast through the lymphatic system. And what lymph nodes are they're actually little filters. So those filters will trap those cancer cells and keep them from going further on into the body. So if that cancer is tried to spread, those lymph nodes are going to grab it and stop it. So that's why surgeons will remove those lymph nodes. The pathologist will put that lymph node under a microscope and look to see if there's cancer cells in there. Right? Because that helps them determine there are no cancer cells in here, which means that thing is probably still an earlier stage and local, and we can change our treatment based on that. If there are some cancer cells in those lymph nodes, they kind of say, is this maybe a little bit more advanced than we thought? Do we need to modify our treatment? Do we need to add radiation? Do we need to add chemotherapy? So it helps your physician team make better decisions on what your best treatment is. Underneath the breast tissue and underneath the lymphatic system, we have our chest wall muscles, and I'll show you these as well. So your pectoralis major is the huge muscle of the chest wall. And then over here on the side is your latissimus, your serratus anterior. And then back here, this guy, the upper back muscle, is the latissimus. So when the breast tissue comes out, all right, the surgeon will typically also take some skin as well. So you just don't have extra skin just hanging on your chest. You want a nice flat chest wall. So to do that, they have to remove some skin. So here's your chest muscle underneath, and they have to take that top half part of the skin and the bottom half, and they have to pull it closed, and then they'll make a straight line incision. So because of that, you actually lose skin length at your chest wall. So sometimes when you can't get your arm over your head after surgery, it has nothing to do with your shoulder joint. It's the fact that you don't have enough skin extensibility or skin length across your chest to allow your arm to move fully. Secondly, now we're looking at the side of a chest that's had a mastectomy. So normally you have skin and then that layer of breast tissue, and then you have the pec muscle. In the mastectomy situation, you now have skin, they remove all that breast tissue, and then now you have skin laying on the top of muscle. And sometimes it can stick. So, because sometimes when two layers of the body that normally don't touch each other, they kind of now touch each other. They can kind of sometimes scar together if people aren't moving enough. So we also look for that post treatments. Make sure that the skin moves fully and nicely over the chest wall. And I'll show you a little video of this in just a moment. So this is what scar tissue looks like under a microscope. On the left, this is normal connective tissue. This makes up our skin and our connective tissue, those layers, the fascia, all that stuff in kind of the glue that holds us all together. Normally, these connective tissues are like nice, long, straight lines that kind of all go in one motion. They bend, they turn, they twist, they can compress, they can lengthen normally. And this on the right is scar tissue. Scar tissue is a completely normal response to any kind of trauma or injury. The body just automatically does it. You have no control over it. I have no control over it. Medication has no control over it, nor does a physician have any control over it. It just happens, all right? And it kind of plugs that hole. But unfortunately, scar tissue doesn't move like normal tissue. It doesn't bend or compress or twist like normal stuff does. So sometimes it can cause mobility limitations, either in the skin, in the muscle, in a joint. And secondly, scar tissue can trap a lot of nerve endings. So when you move and it pulls on that scar tissue, it just creates that continual pain that often people have in their chest wall or their underarm. Okay, so I'm going to show you now a slide. So if you have a squeamish tummy, just want to prepare you. It's nothing gross, but just let you know, this is actually, you're going to see the inside, another picture of this in real life. It's not bloody or gory, but just want to let you know that it's coming. I'll have like 2 or 3 pictures. Okay. So this now is that same picture. So here is the skin. All right. The breast tissue underneath the skin is now completely removed. And this is muscle. All right. This is your pectoralis major muscle. All right. So this is a left chest wall. Here's the left shoulder. Okay. So this is 30 seconds or so after the breast tissue came out. The surgeon just removed it. Now I'm going to show you that same chest wall 365 days later. All right, so same chest wall, all right? And this actually was a female patient that is going back for reconstruction, which is why they're reopening this chest wall. This, my friend, so here's the skin. Down underneath there is the muscle, but this, my friends, is scar tissue, okay? Again, normal response. You don't have to sit there and think, oh, I need to build some scar tissue today. There's nothing that you can eat or do to make it happen or not make it happen. It just happens. Now, this looks pretty thick, right? And you can see that if somebody is not moving during this, then it takes a good year to 1.5 years for this scar tissue to finally stop building. But you can see if somebody's not moving during this maturation process, that they might kind of get stuck where they are. This person, though, was a patient of mine and was pushing and pulling and lifting and carrying and reaching and exercising. So she was completely pain-free, had 100% strength at that shoulder and that chest. She was actually a weightlifter and a taekwondo person. And she had full mobility. So even in the presence of scar tissue, if people are moving during that 1 year to 1.5 years, they don't have any issues with the scar tissue. It's there, but it doesn't bother them. But if it's there and it sticks to stuff and it doesn't allow you to move normally, it's going to be a pain in your hinder until we can improve it. Okay, so, and why that pec muscle is important, okay, we talked about the pec major muscle, is because it attaches to your clavicle, that's your collarbone. It attaches to the breastbone or the sternum. It attaches to the ribs, and it attaches to your humerus or your upper arm bone. So if this pec and that skin doesn't move well, you are not going to move well. All right. So it's very, very important that, again, when the surgeon goes in, they're not touching this muscle. They do have to scrape some fascia off the muscle. And again, the skin over it can get tight. Radiation can thicken it a little bit. But so the pec major, even though it's technically not part of the surgical field, definitely gets affected and will be the reason if you can't move well, why you can't move well. And underneath that pec major is a lot of stuff. People are like, it's just a chest wall muscle. It's just an armpit. Underneath that pec, out of your neck and down the arm runs the arteries and veins. Out comes the lymphatic system. Out comes the nerves. And if that pec or that skin is super tight, it's going to compress that stuff. And that doesn't help a healthy arm or a healthy chest. So I will say, even good range of motion is not good enough. It needs to be perfect. I want it really good. I want your skin to move well. I want your arm to move well. So all of this important stuff can do its job without being stressed. Here is a regular armpit. All right, this is the right armpit. Here is the left armpit. And this is typically what this can look like after a lymph node dissection. The armpit itself can become really, really tight. And sometimes we need to treat that as well. I actually have a picture of that, a little video of that coming up. So here's what a typical mastectomy looks like. All right, here's a gentleman who already had chemotherapy. So this is his chemotherapy port. Normally, it would be on the opposite side, but his cancer surprised everybody a little bit, so he ended up needing chemo after they thought he would need it. And you can see also that he had radiation. So this hair will grow back eventually. But this is what a typical mastectomy looks like. Again, it's that long, thin incision straight across the chest wall. Now, the stretches we typically do, this is Nancy. She's a breast cancer survivor as well. And this is Clyde, actually. Hello, Clyde. So what we do first with people during surgery or right after surgery, and certainly during radiation and after radiation, is what we call the overhead stretch or cane stretch, where you're, again, just reaching your arms overhead. Just putting your hands behind your head, letting your elbows flop down to the side to see. Again, you can see how this would be a really, really nice chest wall stretch. And then getting both arms out to the side and just opening up your chest wall and sliding them overhead, making sure you're able to do that. So after this webinar, I want you guys to hit the floor. And hopefully the cat or dog won't jump on you like, hey, what's Dad doing on the floor? But get down on the floor and really try this stuff. Actually, and my favorite of all, wait, I'm going to go one more here. Okay, this is David. This is what I want you to try when you get the opportunity. Either lie on your bed or lie on your floor. And you're going to lay on your back, arms at your sides, and you're going to bring your knees up and your feet on the floor of the bed. Then you're going to rotate. I'll show you this video in a second. You're going to rotate your knees to the opposite side of your surgery side. And then you're going to raise your arm out to the side, keeping it on the bed or the floor. And you will be shocked at how tight that probably feels. Even if you think you're great, I want you to try this. All right. So this is David. David is also a breast cancer survivor. So he's rotating his knees to the right because his surgery was on the left. And again, keeping that arm flat and just bringing it up over the top of his head. Really, really nice stretch. And he is probably almost 6 months out now. So he can do this, but at first he could not. So this is, if you can't do it, keep trying, keep working at it until that becomes easier. So I'm just going to run through that again. Knees to the opposite side. Keep your arm flat. Palm is up. And bring that out to the side. This is a fantastic stretch. And again, I want people to do this for at least a year to a year and a half after the surgery's done. And if you've had radiation, for a year to a year and a half after the radiation is finished. Again, because of that slow setting cement concept that we talked about with the radiation and the fibrosis. Now, this is George. And George is probably, he's just a couple weeks out of surgery. So this is still pretty new. He's still got some of the tape on him. His skin's a little irritated after surgery. Um, but you can just see, I'm going to show you some times here where he has a lot of trouble. You can see how tight his armpit is here. He's not particularly happy. So he has some cording from the axillary dissection. So it's just super tight in the armpit. So we do a lot of stretching to loosen that up. So in George, he had a lot of problems with his underarm being tight. And now we're going to show you his chest wall is also super tight. So he's missing a good 30%, 40% of his normal range of motion at his shoulder. But now we're talking, remember we talked about the skin has to move over the chest wall. Now I'm just checking his drain site. But look at his skin just does not move well. It's just tight. It's thick. And again, so he not only has a length problem, he also has a mobility problem. So we're going to work on loosening up his chest wall. And believe it or not, that actually feels good to people to have that loosened up and lengthened. Okay, so now when it comes to lymphedema risk reduction, and lymphedema is that swelling in the arm that people can get after lymph nodes are removed from the armpit, whether they're removed for breast cancer, whether they're removed for for melanoma, whether it's for lung cancer. It doesn't matter if lymph nodes are removed from the axilla or the armpit, you are at risk for getting a condition called lymphedema. Now, that risk is definitely lifelong, but the highest risk is in the first 3 to 5 years, okay? And the risk changes based on mostly how many lymph nodes came out. So if you have one lymph node come out, 1 or 2 or 3, you're very low risk. It's probably in the 5 to 10% range. And if you've had a lot of lymph nodes removed, like 25 to 35, you're probably in a 25 to 35% risk, okay? Now, the best ways to reduce your risk, okay, or keep your risk as low as possible, is we want you to regain full mobility and strength at that shoulder and that chest wall. Because remember what's underneath that pec major? That's where your lymphatic system is. So the more mobile your chest wall is, the more mobile that skin is, the happier and healthier your lymphatic system is going to be. Excuse me. So the studies also showed that people that are overweight actually have a higher risk of getting lymphedema. So we either want you to try to maintain your ideal body weight if you're already there, or work towards getting to a more ideal body weight during and after your treatment. One of the largest precipitators of lymphedema is getting an infection in that particular arm. Okay, and that's usually a cellulitis kind of infection, which is an infection of the skin. So people would see a redness in the arm, pain in the arm, swelling. Any of that is not normal. If you see that, we would want you to either go to urgent care or call somebody on your medical team and just say, hey, my arm is kind of red. Do you think this might be a cellulitis? They would likely get you a antibiotic to treat that infection. Okay, so if we want you to make sure that, again, and because you are at risk for infection, doesn't mean you can't garden or golf or hunt or dig or play in the mud or go ride your ATV. All of that stuff is fine. Okay, but if you see signs of infection, we just want you to act on it quickly. And then another huge, huge thing you can do to reduce your risk is regular exercise. So what moves lymphatic fluid is movement of your arm, increased heart rate, increased breathing rate, and muscle contractions. So that all screams of exercise and activity. So when you are out digging a ditch, you are actually reducing your risk of lymphedema. When you are in the gym, you are reducing your risk of lymphedema. When you're playing with the grandkids, you're reducing your risk of lymphedema. So that's all good. So regular exercise, making sure that chest is fully mobile, fully strong, that you're exercising well, and watching for signs of infection. That is the best way to reduce your risk of lymphedema. Okay, so before we talk about chemotherapy and radiation, I want to talk about fatigue, because that is probably the primary reason or primary cause of fatigue is both chemo and radiation. So 90% of people report fatigue with chemotherapy, whether you're young or old, Doesn't matter. Okay. Not only is it the most common side effect, it's typically the most distressing. So it's one that we really want to focus a lot on, especially because we know that people that exercise have less fatigue. It's one of the best treatments. And for many people, that fatigue can last months or years after the treatment is over. And again, that is not okay. So again, getting people moving, getting them stronger, getting them healthier is critically important. So technically, we actually don't know what causes cancer-related fatigue, like on a cellular level, but we do know that things can certainly contribute to it. So anemia, obviously, pain, emotional distress, when your sleep is messed up, when your nutrition is messed up, when your activity is messed up, that can contribute to fatigue. Things like if your thyroid is off, if your heart isn't pumping well, if you have an infection, all of that is going to contribute to fatigue. But if you erase all of that stuff, most people are still going to have some level of fatigue that isn't explained by this. Okay. So it's not just a matter of eat better, sleep more. It's just a thing. And one of the best things for that is, again, exercise. We've talked about this already. So it's that 150 minutes per week. Okay. And so I don't care how fast you go. I don't care how far you go. I don't care how fast you're working, because if you're 70 and in great shape, and you're with a guy that's 50 and out of shape, the 70-year-old's going to have to move faster and harder to get moderate than the guy that's out of shape, even if he's 20 years younger. So age and doesn't really matter. You just need to move to a moderate pace for you on that particular day. Okay. And again, we want 4 to 6 days. So most days of the week, we want you doing something to increase your heart rate for a sustained level, even if it's for five minutes. Yes, 10 is better than 5, but 5 is better than 0. So just get yourself moving. And then twice a week, we want you doing some strengthening to your arms and legs. Now, you do not need to go to a gym. You don't need to buy equipment. You don't need to wear fancy shoes. You can do this in boxer shorts and a t-shirt if you want. So things like just sitting to stand from a chair, up and down from a chair, doing push-ups against the wall. That's great, because when you do push-ups against the wall, you're using at least 5 to 10 different muscles. When you sit to stand from a chair, you're using at least, again, 5 to 10 different muscles in your legs. So just those 2 things alone would be great to do 2 or 3 times a week. So don't make it hard. Okay, so let's look at radiation. Many of you that have had radiation will recognize this machine. It's called a linear accelerator. And again, the radiation oncologist and their team will set the lines of the radiation fractions that go through you to target the tumor without hitting your bone or your muscle or your heart or your lung. And the side effects, again, we've talked about. Fatigue is number 1. Skin reaction is another one. Obviously, that's when your skin gets pretty, if you're either really red or really, really brown, depending on your skin color. And that can lead to pain, and that can lead to limited function. So down the road, people can still have some permanent darkening of the skin. Sometimes they'll get red, spidery red marks, the little blood vessels that are trying to get through again. And again, myofascial restrictions. Again, muscle is myofascial, means skin and connective tissue, so that those restrictions can cause immobility at the shoulder, immobility at the chest wall, the rib cage, and that can cause pain and numbness. So here's Mr. Riley. He is just finishing up his radiation. So they're radiating his chest wall, and they're also radiating his lymph nodes up here because he had a more advanced breast cancer. Here is his chemotherapy port. So he's almost done. So his skin is getting pretty trashed, but he's doing well. He's walking regularly. He's lifting weights. He's stretching. So this is what somebody looks like I think he was in his last week here. And then here is his underarm. So you can see he's still moving pretty good. So we want him to continue, as this skin tightens and thickens now over the next year and a half, that he needs to keep stretching to maintain this tissue length. Because if you don't move and that stuff shrinks, you're going to be stuck there. And yes, you can unstick that, but it's a lot harder than just keeping it long in the first place. Now, this is Bill. This is Bill's non-involved right armpit. And this is Bill's left armpit. So this is not normal. This is really aggressive radiation fibrosis. Okay. So here is those little teeny red blood vessels we were talking about. And again, this shows you kind of how that fibrosis can really kind of block blood flow. It can block skin, normal skin. So his shoulder mobility was limited because this was so tight. And yes, we can't make that skin fibrosis go away, but we can soften it. We can lengthen it. So he was able to become pain-free and really improve his range of motion almost to like 80% of normal. So again, when it comes to treating somebody with radiation-related issues, whether it's fatigue, again, it's going to be that 150-minute per week target again. Again, anything's better than nothing. And then again, as far as that strength and function at the shoulder, it's going to be stretching and strengthening. And I can't hammer this home enough because people just finish treatment and they just want to put it behind them and they start to feel really good. But we really want you to stay on that stretching, that one stretch that David showed you, that trunk rotation stretch, okay, just to maintain that length as the body heals and as you recover, just to keep it there as that thing shrinks. So the best way I can describe that is if you take a piece of like Wonder Bread, a white piece of bread out of the package, all right, you take it out, it's floppy, it's loose, you can stick your finger in it and it rebounds, but you leave that piece of bread out on the counter overnight. It feels a little different the next day, doesn't it? But you leave that piece of bread on the counter for a week, for a month, for a year. What's going to happen to it? It's going to tighten, it's going to shrink, it's going to lose moisture. And you never see it happening, but it just slowly happens over time. That's kind of what radiation fibrosis and scar tissue are like. So during that process, we want you just to continue stretching to maintain that tissue length as those tissue changes happen. All right, so now let's move on to chemotherapy. And again, we've already talked about this. So fatigue, bone loss, muscle loss, neuropathy, heart function, weight loss, weight gain, anxiety, depression are huge. And again, very underreported, underaddressed. All right. And again, I'm going to say the same thing, that target of 150 minutes per week of moderate exercise, again, for you. Or if you are in treatment, moderate may be walking to the mailbox and back. Okay. If you're on a day where you're like, actually, that's my cycle. My chemo was like 10 days ago. So maybe moderate would be walking around the block. Okay. So it's going to change day to day, and that's okay. But getting your minutes in, again, I don't care how fast you go. I don't care how far you go. Just get your minutes of movement in. And again, we want you to strengthen your arms and your legs about 2 to 3 times a week. So here's just some clinical pictures. This is Jerry, just doing some aerobic exercise here in the clinic. At home, he was walking, and I think he did something, a YouTube video, I think, where he did some Tai Chi in place and some boxing moves, I think, just something to keep him moving. And then here is George again. And again, he is 2 or 3 weeks post-surgery, but we've already got him starting to lift some weights because it's so important. So here, this isn't bothering his chest at all. So it's a 5-pound weight. But again, this is going to be for his tricep muscle. But again, it's just a nice way to get things moving. So no matter how out of shape you are, because George was out of shape, and no matter how soon you are from your surgery, there are safe things that you can do to get those muscles moving again. And again, during chemotherapy, exercise is safe and beneficial and actually will improve your outcomes substantially and reduce fatigue. This is my poster child. This is Charisse. She was getting inpatient chemotherapy for leukemia. And so no matter how low somebody's counts go, exercise is still safe. So no matter, again, if you're still in treatment or if you have a family member, a friend, or a colleague or a neighbor that's in treatment, even if their counts go down, white count, red count, blood count, we need to modify things a little bit, but people should be exercising. So one of my mottos is, if you have to be bald, we want you bald, smiling, and sweating, because we can make healthy cancer patients. We really can do that. So we really need to shift the narrative about be careful, don't do too much. Yeah, people should help you. We want, yeah, you're going to need to rest more, probably sleep more, but you need to move and exercise more as well. We've got to change the thinking because we've been doing people a huge disservice for the last decades, and that is what has created this massive bubble of people in survivorship that are miserable, and it's not okay. All right, so let's talk about cancer survivorship. And when it's over, it's not always really over, said nearly every cancer survivor ever. And again, this is the phase of cancer treatment or cancer survivorship is the phase from the end of treatment when your primary treatment is over, and for the balance of your life. All right. So everybody just kind of thinks we call it the myth of the finish line. It's like you get done. Thank God it's over. You've been through a lot. You've been through hell. It's been traumatic, and now it's done. And you just want to put it behind you and move on. Not so easy when you are living with a lot of the crap that the treatment has left you, especially if it hasn't been addressed by a physical therapist. I mean, imagine having a stroke and not getting a PT. Imagine having a knee replacement and not having PT. Well, that's what we're asking our cancer patients to do, and it's not fair. So in survivorship, these are the things that we need to keep looking at, making sure people are still on a fatigue-related exercise program. Because again, we learned that fatigue continues. It just doesn't stop the last day of your cancer treatment. We know that exercise reduces the risk of cancer recurrence. That's the whole reason we treated you. But we know that people aren't exercising enough in survivorship, even though it can reduce risk of dying from cancer. So we need to support people in that. We need to support people in bone density, especially for those of you that are on the estrogen blocking medications. All right. We need to help people with body mass index. Whether your body mass index is too low or it's too high, we want to bring you more towards the middle again. And again, how do we get people exercising when they have the aromatase inhibitor or tamoxifen-related muscle pain? How do we get them exercising when their feet and their hands are burning from chemotherapy? So there's ways to get around and modify that, and we'll talk about that. So from hormone treatment alone, which most guys are on, and the guys that do hormone treatment for prostate cancer and testosterone, testicular cancer, same kind of stuff, right? Changes in body composition, changes in muscle, usually weakening, changes in bone density, changes in mood. It's just gross and it just doesn't feel good. Exercise has the ability to minimize all those symptoms. It'll improve mood. It improves bone density. It decreases muscle weakness. It helps modify your body composition. So it really is a wonderful tool that can help so many things. So when it comes to CIPN, so that's chemotherapy induced, it means chemo caused it. And peripheral, it means the end of your body, so the hands and the feet, out towards the periphery, all right? And neuropathy just means changes in your neurosensory function. So many chemotherapy drugs can cause this. Some are more high risk than others. So I just want to first of all say that neuropathies are not fully preventable, all right? Because if they were, we would do that, okay? And they typically happen in the hands and the feet. They're usually bilateral, which means they happen on both sides. So if one day you wake up and only your right hand is problematic or is numb, but your left one's fine, chances are that might be something else, a pinched nerve in your neck or perhaps carpal tunnel, because typically chemotherapy-related stuff happens on both sides. One might be a little bit different than the other one. And they're typically the whole thing, like somebody put a numbing glove on you or numbing socks on you. All right. And typically, again, there really is no cure for neuropathy, chemo-induced neuropathy. And sometimes permanent neuropathy is common, all right? Because again, if we could give you a pill for it, if we could fix it, we would do that. So I don't say that to be depressing. I just say that I don't want people with neuropathy chasing all these things online that promise cures, because it's not out there. So always talk with your medical oncologist first. If you want to try something, go right ahead, but let them know first so they can help you either make sure that it's safe and or that you don't spend a lot of money that's on something that we know isn't going to help you. All right. So again, exercise. If you have muscle and joint pain from tamoxifen or any kind of anti-estrogen medication that you're on, exercise will definitely reduce that pain. Okay. But when it comes to chemotherapy neuropathy, exercise isn't going to typically fix that. All right. However, exercise will improve your balance. It'll improve your walking. It'll improve your strength, your safety, and your function. Right. So that is really important. And I will say that it's better to be strong and have neuropathy than to be weak and have neuropathy, because I've seen both. And I'm not, again, I don't want to minimize how horrific this can be for some people. And you're like, my feet feel like they're getting stabbed, and you want me to take a walk? Yeah, some might do. Or we need to get you on a stationary bicycle, or we need to try get you in a swimming pool, maybe. Because I've had people with neuropathy, and again, it has to fit you. Because I've seen people with severe neuropathy say, "Oh my God, I get in the water, and it's so much better. I can swim, I can walk." And other people say, "Oh my God, you put my feet in water, and I scream. It gets worse." So you have to find what matches you and works for you if you are living with this. Again, get your physician to get you to a physical therapist to help you with this. You deserve that. Uh, hmm. And here's this guy again. One of the greatest things you can do right at home is stand on one foot, and you can see he's got his eyes closed. It takes away the visual input from your brain, and you'll be surprised. Even if you don't have neuropathy, this is something I recommend that every human do at least once a week, once you are 50 years old and beyond. Again, just to kind of maintain that ability for your foot and your ankle to talk to your brain when your eyes are closed. All right. So just stand near something that you can grab onto or hold onto, and maybe do 30 seconds on your right leg and 30 seconds on your left leg. And I would do that once or twice a week. And the worse you are at it, the more you should probably do it. Okay. Because yes, you can't make the neuropathy go away, but you can improve your balance for sure. And that is incredibly important. Because again, this is what helps you not fall over. This is what helps you on the basketball court. This is what helps you when you're mowing the lawn. This is what helps you when you're going up and down the stairs, playing with your grandkids, playing pickleball, whatever it is, or just walking to the kitchen to get your breakfast. All right. You've got to be able to maintain the ability to do this stuff. All right. So I want to close again with a statement that shouldn't feel profound, but it is. You deserve and should expect after cancer to return to full strength, full comfort, full mobility, and full function. All right. I think there's this overwhelming kind of underlying assumption that I've had cancer, I've had chemo, I've had radiation, I've had surgery, I'm never going to be the same. It's just the way it is. That's bull hockey. All right. You do deserve and have the ability to return, and it may be not 100%, but for a lot of people, it is 100%. Right. But better than you are now for sure. So please, if you don't feel really good, either recontact your physical therapist, even if it's been years, and or get into a physical therapist. Again, it doesn't matter how far out of treatment you are, or if you're still in treatment, it's never too early and it's never too late to make sure that your body gets exactly what it deserves after it's been through something horrific. Before we go, I want to tell you about a new podcast. I think Sherry has been sharing this with you on your Facebook page. It's called the After Cancer Podcast. And I am the host, and we talk about this stuff that people don't normally talk about. And it's designed specifically for the part after treatment. We do talk about chemo, radiation, surgery, and all that stuff. But mostly it deals with the other stuff that people don't typically talk about. So please, you can find it on YouTube. Just put in the search end, the After Cancer Podcast, or you can check out this QR code here. It's also on most listening platforms. It is being listened to on 30 countries all over the world. And we have, I think, almost 45% of the people that listen to it are male, which makes me really, really happy. Because as you guys know, talk about lack of representation. So that makes me really happy. So I'd love to have you join in. I'd love to hear what you think from your perspective. So feel free to comment and email me and let me know what you want to hear about. Because again, I want your voice to be heard because it's incredibly important. So thank you. I know Sherry has been watching the chat. Again, I appreciate the opportunity to spend this time with you. And Sherry, thank you for the opportunity to spend time with your great organization. And I'm happy to hang out for some questions if anybody has some.
Thank you. Thank you. Yes, I have been putting probably not all the sessions because sometimes I miss them, but yeah, your podcasts are extremely informative, and I encourage everyone to take a look at them and ask the questions that you want answered.
Yeah, thank
Um,
you.
we have a couple here. Someone commented that carpal tunnel seems to occur commonly with aromatase inhibitor drugs. So,
Yes, it doesn't cause it, but if you got something, it's going to make it madder than it already is typically. So we'll see that if somebody has an old ankle injury or an old knee injury or something, aromatase inhibitors can flare that up. So what we think is happening is, again, even the muscle and joint pain that people have, and it can be pretty significant, makes you
mhm.
feel like you're 90 years old, is the joint is not actually damaged. So the aromatase inhibitor isn't damaging anything, but it alters the way the pain nerves function. Because who knew? We need estrogen for those things to work correctly. You take that away, all of a sudden these things just start firing away like crazy. So it didn't cause the carpal tunnel, but it can certainly flare up and make your joints feel like they're 90 years old and your muscles feel like they're 90 years old. So
Okay.
again, we do know that exercise can help that improve. And what's nice about the tamoxifens and the aromatase inhibitors is when you stop taking them, which can be 5 years, or sometimes longer for some people, that when you stop taking them, that pain will go away. Okay, the pain related to the AI will go away. With chemotherapy neuropathy, you get neuropathy during chemo stops, neuropathy continues. But when it comes to those estrogen medications, it's very different. So just kind of hang in there, know that nothing's being damaged or broken. And movement helps. And once you come off the medication, it go usually in a couple weeks, it goes away.
Oh, good to know. One of our uh, guests actually is a marathon runner, and he was saying how he started to notice the cording.
Yeah,
And that's when he started the PT, that he was
good.
actually given stretch exercises by his oncology team.
Yep,
However, when he noticed the problem, that's when he was told that PT
yep,
would help.
yep.
How would someone go about getting a referral from their oncology team for physical therapy? I mean, I'm asking a question that us as an organization, we're actually looking to highlight exercise as rehabilitation. And it is something that all patients should be getting information
Mhm.
about, should be given a referral for.
Yep.
How are you able, who would you talk to, and how do you find the proper ones? Because all PT is not the same.
Right. I think any PT is going to be better than no PT for sure, because some people just don't have access to a cancer PT, right? So it doesn't have to be, you just get one. I wouldn't travel 3 hours if you don't have to. So the first thing I'm going to say is you don't have to get a referral from anybody on your cancer team. It can come from your primary care physician. All right. It can come from any physician. So anybody with an MD, a physician assistant, a PA, or even a nurse practitioner. Right. So it doesn't have to be a cancer related person to get you to a physical therapist. All right. So that's really important because some people are like, I haven't talked to my cancer docs in years. So get one from your PCP. It can come from your next door neighbor if they've got an MD or a PA or an NP. All right. So that, excuse me, I'm sorry. So I think that's the most important thing to know. And we are working very hard is you shouldn't have to ask for PT. It should just automatically happen in a cancer center. And we're working very hard. And that's actually happening in many places across the US and in many places across the world. We've got a ways to go yet.
Mm,
So, because the marathon runner shouldn't have had it, I mean, yes, you can get stretches from your medical oncology team, but you don't get stretches for your knee replacement from your orthopedic surgeon and expect that's going to make the things go because it doesn't. It's just not enough. So everybody should. So just call any of your physician's offices. It can be even your cancer nurse navigator can usually just make a phone call. So you can call a nurse and just say, hey, can you get me an order? Who do I talk to? And the one of the disadvantages of having cancer is you usually have like 5 doctors. But the nice thing about that is one of them is going to give you a referral. And it doesn't, honestly, does not matter which one it is.
okay. When is it actually safe for a breast cancer survivor to start exercising? Is it after surgery, chemo, radiation, anywhere in that time frame?
Okay, so exercise and rehab are two different things, but if it's specifically exercise, it's safe immediately. As soon as you hear the words, you have cancer, we want you on a walking program. All right. So even if you had surgery yesterday, you can still take a walk. Okay. So what's important though is the exercise may need to be modified a little bit because after surgery, exercise with your arms is going to change. All right. But we still want you walking. All right. If you've just had, you've got bone mets in your leg, your exercise is going to change, but you're still going to be exercising. So exercise is safe and beneficial every single day of your life. It may just need to be modified based on what's happening to you right now. That's why a physical therapist is important. But walking is pretty much always generally safe. However, we don't want you to wait until you're trashed to start intervening. So we want people to be active and start physical therapy and start exercising as soon as possible and continue it through the entire treatment plan: surgery, chemotherapy, radiation. Everybody should be moving, walking, and then into survivorship. But it modifies and changes based on what's happening to your body. But always moving is always good.
Okay. Is there a difference between the rehab that men would receive as opposed to women after a breast cancer
Not
surgery or nothing?
particularly. Not particularly. I mean, skin and muscle. You remove all the stuff on the top. Underneath, it's pretty much the same. So again, you saw George's underarm that was cording, the soft tissue restrictions at the axilla, moving the chest wall. Because we're not treating really, we're not treating chemotherapy, surgery, and radiation. We're treating the side effects of those things. So a good physical therapist will treat whatever you have, right? So if your chest wall moves great, I'm not going to spend time on it, right? So whether you're male or female. Now, certainly what your life is matters based on gender sometimes. Jobs are often different. Family roles are often different. Body mass index is sometimes different and activities are different. So we have to base, like if you climb ladders and you lift, I don't know, you use a front end loader every day, or if you're a firefighter, that's going to matter versus whether you're a childcare person or you sit behind a desk all day. So that matters more than gender does.
Okay. Are there specific precautions after lymph nodes have been removed for weightlifting?
There are not. Actually, weightlifting has been shown to be protective, protecting you against lymphedema. What I would say though is we want to make sure that you're lifting. You saw George lifting a 5-pound weight 2 weeks after his surgery to get his tricep moving. All right, but I wouldn't want him leaning forward and bending backwards and doing it, or he can't get his arm over his head. So what the limitations, not really limitations are, but what the baseline is, we want to make sure that your shoulder functions normal, that your skin's moving normal, your range of motion is normal. So when you're doing that, you don't injure your shoulder joint, okay? That you don't injure your back because your mechanics are all messed up. So once you have good mobility, that skin moves well, your range of motion is normal, that you kind of rehabbed and your bicep, your tricep, your chest muscles, your scapular muscles are all doing well. As long as you progress, don't go from 0 to 100, and just start with 5 pounds, 10 pounds, or whatever feels, just gradually progressing up the chain. It not only is it safe, it's actually beneficial for you. And there is no limit. There are people who are Olympic weightlifters, and I have weightlifters myself, who've had lymph nodes removed. And I have weightlifters that have lymphedema. And one of the best treatments for lymphedema is exercise and weightlifting. So it's just very, very good for your lymphatic system.
Awesome. Are there specific dietary recommendations that support muscle recovery and overall wellness?
That's not my area of expertise. You're going to want to talk to the cancer dietitians are fabulous.
Okay.
So check in with them. What I will say is that in general, there is no magic. I can promise you that there's no magic bullet. They're going to say, "Oh, eat this and you're going to be fine. Eat this, you'll never have a recurrence." And I promise you that's not going to happen. Even though the people on YouTube and Facebook will tell you that. So in general, we want people to eat, if you have general health, you're generally doing well, just a plant-based diet. And plant-based diet does not mean not eating meat. Okay.
Right.
That's a really big thing to import. Doesn't mean not eating meat. So you can have meat 2 or 3 times a week, just smaller portions of red meat, and using more white meats. But mainly that just means what's a plant-based diet? It's mostly you just really want to eat like lots of fruits and vegetables, lots of fiber. All right. That's the best diet for somebody who has a history of cancer, whether you're male or female, young or old. That's going to be generally the answer based on research. If you have, I mean, if you're like one of those really gym bros and you're like, I got to get some muscle, I would definitely talk to your dietitian because there are things that you can add to that and change a little bit. Or if you are really underweight or you've really been sick, you may need to boost your protein because of that. So again, the best person to talk to is a registered dietitian, hopefully with somebody with a cancer history, cancer experience, and they're out there.
Yeah. How long should rehabilitation continue after active treatment ends? And I think you answered that earlier. Just
Yeah. So that's going to be based. I mean, honestly, you and your physical therapist should have a lifetime relationship. Okay. I offer lifelong care to my patients because once I close the door, if they're doing really well and they're exercising regularly, I'm not going to make them come into the clinic and see me. If you have any questions, give me a call.
Mhm.
But my door never, I mean, they'll walk out the door, but it never closes behind them. So, because there are going to be times when 5 years later, you may have trouble because of the aromatase inhibitor that you're on, or all of a sudden you gain weight from something else, or all of a sudden, like, wow, this has got really tight on me and I didn't realize it, but now I'm 3 years out of radiation and my chest feels tight. So, um, again, my apologies. So your relationship should be lifelong. For some people, need very little rehab. Coming out of surgery with no pain and no limitation is totally normal. Okay, that person doesn't need a lot of physical therapy. Some people go through radiation and chemo and they have very little fatigue. They have very little problems, but they're not the ones that we hear from, right? Because they're happy. They're like, I'm not got nothing to complain
Yeah.
about. It's also very normal to come out of surgery feeling miserable and having a lot of pain, not being able to touch your nose. That's also normal. So the range of normal is very wide
Right.
with all treatments and people's reactions to them. They're all normal, but the range is huge. So the more problems you have, the longer your plan is going to last. All right. If you, I'm not going to make people come in if they don't have trouble. So it's going to be based on that individual person, but typically it should lifelong care is what we offer.
Okay. What would you suggest for other countries? We have someone here mentioning that in the UK,
Hmm.
the referral process to a physio does not happen, and they
Yep.
have to privately go and find these things on their own. What do
Yep.
you suggest for something like that?
Well, I do have colleagues in the UK. There are cancer physios. So I would check again your websites, check with ESMO. Um, because there are, I know, especially maybe London-based, the larger cities tend to have more active resources than the rural areas. But keep looking around and find somebody. But then it's really important to go back to your nurses, go back to your physicians, and say, listen, because the lack of physical therapists or physiotherapists is an issue in some places. But the
Mhm.
biggest issue is they're there but nobody knows because the physicians and the nurses aren't automatically incorporating that in. So I apologize if you have to go look for somebody. It's not fair. But talk to somebody in the larger cities and like Percy Health. Check out Percy Health. It's PERCI, which is located in, I think, the southern UK. They do a lot of rehab stuff. But again, when you find somebody, a physio, even if it's a local physio that does backs or knees, that's still going to be better for you. But go back to your physician and say, this helped me. You need to be doing this. You need to incorporate it. And how are you going to do it? All right. So they're the ones that have to really do that. So they're the people that really need to hear my voice as well as your voice. I hope that answered your question.
Okay. Maybe that's something that you and I can visit separately, where we might be able to build more of a resource for something like this on the
Mm-hmm.
website eventually.
Mm-hmm. Mm-hmm.
Um, and if you could give every breast cancer survivor one piece of advice about regaining strength and improving quality of life after treatment, what would that be?
Um, I would say, again, I would go back to that. You deserve to feel well and to be normal and to get back to normal. I would say exercise like your life depends on it because it does. And the biggest thing I think is treat yourself like you're the most important person on the planet because you are. And if you don't treat your body well, where are you going to live? Right. So, and then your voice is important. I always say that research and physicians and medical people improve cancer treatment. Survivors' voices improve cancer care.
Wow, that's
Yeah.
powerful.
Yeah.
Well, I thank you very much. I don't have
My
any other
pleasure.
questions. If anybody has any questions after this, by all means, feel free to email me, and we will get them to Dr. Waltke for responses.
Yep. And
Okay.
you're welcome to share. You're welcome to share my email address as well.
Wonderful. Thank
Yeah.
you.
Or reach out
Yeah.
through the After Cancer podcast or on YouTube or something. I'm easy to find.
Okay. Thank you so much. We
Thanks,
appreciate
everyone.
it. Have a good day.